Hello, everybody, and welcome to this Care Partner Q&A featuring Dr. Jori Fleisher. This is a part of our Care Partner training program and series. And if you are watching this as a video recording, you're not live today, you can find a link to the whole Care Partner training program in the description of the video. If you're here live, got some instructions for you all as our attendees. In the meantime, before I do that, I'm Polly Dawkins, Executive Director of the Davis Phinney Foundation, and I am really glad to be back with our friend Dr. Jori Fleisher to address the questions that you all have given us and you will give us in the chat today about being a Parkinson's care partner. But before we go any further, let's introduce Dr. Jori Fleisher. Hi, Jori.
Hi, Polly. Thanks so much for having me. Thank you to everyone who is joining us live. Thank you to everyone who is watching this after the fact. It has been such a joy to be a part of this. I am a movement disorders neurologist, so I see folks and families with Parkinson's. And on the days I'm not in clinic, I'm thinking about them and working on research. So it's a joy to be here.
Well, thank you. Thank you. And tell us where are you calling it from? Where do you work?
Oh, sorry. I am at Rush in Chicago, Illinois.
Wonderful. Wonderful. Well, for the live audience, in today's conversation, you have a few different options about how you will interact with us. And some of you have already started using that chat feature. That chat feature will allow you to ask us questions. And my colleague Annie will be in the chat. She'll be dropping some links in. She'll be adding additional information. She'll be helping us sift through some of the questions. And but that's how you can introduce yourselves to one another. And if you don't like seeing that chat function, if you don't like seeing if you're distracted by all those chats, you can hover over the chat button and hide the chat. Similarly, there's a closed caption feature. If you like seeing the words come across the bottom of your screen, you can turn that on. If you don't like that, you can hide that and not see them. We will not be using the hand raising feature, and we will not be using a Q&A feature if you happen to see that. So those are not available to us. If you raise your hand by mistake, we won't be able to answer you live. And we can't see you and we can't hear you, but again, we can hear you, your words in the chat. So hello to everybody who's saying hello. Before we get started with your questions for the live participants, we have some questions for Dr. Fleisher, for Jori, that have come in from our care partner community ahead of today. So we'll answer some of those first, if that's okay with you, Jori?
Of course.
And then we'll jump into those of you who are asking us questions in the chat today. So the first question, we're going to just jump right into it, is a question about anger and anger in a care partner. And the person writes, my husband's most problematic symptoms of Parkinson's are Parkinson's, dementia, and low blood pressure. He's a constant fall risk. I hover over him, hoping he won't pass out. I live in constant fear that he will end up in the hospital again. I notice that probably due to exhaustion, my fear manifests itself as anger. I don't feel angry at him. I feel angry at the disease, but my poor husband has to bear the brunt of it. I feel like a different person, as if I have never felt such anger before in my life, to the point of sometimes screaming into a pillow. How does one deal with misguided anger?
Well, I think this is such an important question. I think this is such a hard question, and I'm really glad that we started off with it because to that care partner who wrote that, you are not alone. So I hope, even though I wish no one would have to experience this, the same way I wish no one would have to experience Parkinson's, that if you are on this call, live or recorded, and you're going, oh my gosh, I feel like I could have written that question, right? This is something I hear in clinic frequently, whether it's because of the low blood pressure or for some other reason related to Parkinson's. So I want to sort of tackle those. What I hear from, sort of in that moment from that care partner is they're recognizing this is not their loved one choosing to fall. This is not their loved one choosing to act unsafely. And I think that's really key. Right. So there are a lot of symptoms of Parkinson's that can make someone a fall risk. that are outside of their control. So here in this instance, she's mentioning her husband has low blood pressure, right? Or that neurogenic orthostatic hypotension, where a person changes position, all the blood flow is really down in their legs, down in their gut. They're standing up, and there's not enough blood getting to their head for their brain to really process what they need to do. And so in those moments, even though the person might have gone to every physical therapist and know all the right things to do, they don't know it in that moment.
Mm.
Not because they're not trying, but because their body is literally saying, I don't have enough blood pressure to keep everything running. Right. And so in those moments, recognizing this is outside of that loved one's control. Right. And so I think that care partner, I mean, 100% correctly says, I know it's not him. I'm mad at Parkinson's. Absolutely. Be mad at Parkinson's. I'm mad at Parkinson's every day. Right. So you can't use that anger and displace it towards the disease. Right. And if you can separate out what is your loved one and what is the disease, what is a condition? I think that is really important. That's a huge step. Focus on what you can do in that moment. What does my loved one need? If they're standing up and we need to help them, right? Or we need to say, you need to sit down for a moment. It looks like this is not a good time to stand, right? You're not safe right now. That's also okay to say, right? And as long as they're safe, when that anger is still there, of feeling like you need to hover, right? If you can take a moment, absolutely go scream into a pillow.
I was going to ask, is that an okay strategy?
Absolutely. It can, that word that you scream into the pillow can have as many or as few letters as you want it to. That's fine, right? Because that is not harming anyone, and that is a way to blow off that steam. We all need to blow off that steam, and that anger is normal, right? It's a normal response. I'd be concerned if there are care partners out there who aren't angry about some of the things that they have to go through, that their loved ones have to go through, right? So punch the pillow, right? If you have a boxing bag and that's something that's helpful, get gloves on so you're not hurting yourself, take a swing at a boxing bag, right? Punch, scream into a pillow, do whatever it is that you need to do, so that you can let that steam off and return more whole, to your loved one.
Yeah, that's a great advice. For those of you in the audience, the live audience, you can use your react button. And if something that Dr. Fleisher is saying that you react to and say, yes, this is how I'm feeling, thumbs up, exactly. This is my experience as well. Yeah, so we get some feedback from all of you. Thank you. Thank you. Thank you. All right, next question for you. When my husband is in one of his funky moods, he can be very mean and condescending to me. It hurts. But I tell myself it's not Alan speaking. It is the Parkinson speaking. But he never seems to be aware that he is not being nice to me. Do I tell him that he is acting awful to me when he is doing it? I have tried telling him in the moment, but he just looks at me like I'm crazy. Is he aware of this behavior?
I think this is a really tricky situation, and I think this might bring together a couple of different things. So, one, he might be in a funky mood because he could be experiencing depression, right? Depression affects at least 40% of people with Parkinson's at some point, along the course of this. And it's not just, well, I'm sad because I have Parkinson's and you'd be sad too. Everyone is allowed to have an adjustment period, an adjustment reaction, what we call adjustment disorder, to any life-changing diagnosis. But what I mean by depression is there's an actual shift in the chemistry of the brain so that the chemicals that help sort of regulate mood and anxiety, like serotonin and norepinephrine, these are other chemistries that sort of keep us on an even keel and keep us us. And it's not dopamine, but Parkinson's isn't just a dopamine story. And so, you know, Alan could be experiencing depression and either talking about his feelings with a therapist, with a counselor, a psychologist, a psychiatrist, or considering medications that could help. Not, I think sometimes we think about antidepressants. They really are aiming to restore that person's normal balance back to them, right? It's not changing Alan into someone that Alan's not. It's bringing Alan back to who he is. right? And so if there's some depression going on that's contributing to those funky moods, I think that's really important to treat it. Um, the other thing that's really interesting and that I personally wasn't so aware of until I had to dive deep for a talk earlier in the year was this idea of social cognition. What does that mean? That has to do with like, even though we've got video cameras and stuff, if I say something weird and Polly makes a face and I go, uh-oh, I probably said something wrong, right? That, we all recognize each other's facial expressions and adapt during the conversation, right? If I say something at home and realize, oh, I think my husband just took that the wrong way, hopefully I retrace my steps and, try to correct that miscommunication. What we know is that that relies on a lot of different things. That relies on watching the person's expression. And people are actually constantly sort of scanning the other person's face, looking at their eyes, looking at their mouth to see, are they smiling? Are they frowning? Are they clenching their jaw? And people with Parkinson's in studies do less of that facial scanning constantly during a conversation than someone without Parkinson's.
Didn't know that.
Right? I didn't know this either. And it's fascinating. And so you could be having a conversation, the words are going back and forth, and Alan, right, or the person with Parkinson's is literally not picking up on what your face would have told them 5 or 10 years ago. And
Mm.
what we know is it's easier for people with Parkinson's to pick up on happy or positive expressions. They are more likely to miss negative nonverbal cues. So, for this person, for Alan's, partner, she or he might be, like, right, reacting or clenching their jaw or looking sad. And Alan is literally not picking up on that. And so, this is something, and I often see this in my clinic, is we know that people with Parkinson's make less direct eye contact. I have folks who are sitting and talking with me, telling me their story, and they're kind of looking off to the side. And you can imagine if that is happening constantly, especially in your closest relationships, what that could be doing, right? The person without Parkinson's feels unheard, unlistened to because quite literally there's no eye contact. And the person with Parkinson's does not realize that. And so something as simple as, Alan, can you look at me? That alone may make part of the connection better. And I would say in the moment may not be the best time to say, hey, you're being really mean right now, because it might not be heard. But maybe thinking about it later at a calmer time and saying, I really want to talk about something that went on earlier. And I'm not sure that you recognized this, but here's how this felt to me, right? I would use all of the I statements. I felt like this was happening, right? Not you were being mean, you were doing this. I felt like I wasn't heard. I felt like you were not, picking up on what I was feeling. And that's something that you used to be really good at. So things like that can be helpful. Did
Yeah.
you notice that? Did you notice that I was looking like I was about to cry or I was clenching my jaw or whatever it is that you do when you're upset? Did you notice that? Would it be more helpful for me to say next time, I feel like you're in that funky mood again. I'd like to continue this conversation later when you're not. And I'm going to step out of the conversation now, right? It's okay to distance yourself in that way if you feel like you're not being heard. That's okay.
There is so much in what you just answered there. We could just tease that all apart and come up with some great action items, which we may do because that was great,
Right?
Jori.
I think when I was looking into this, one of the things that resonated to me most, sorry to make this even longer, but one of the things that we do as humans, right, is if we're having a conversation, we mirror each other,
Mhm.
right? And I put up really great examples in a talk about people who are really good mirrors. And if you, regardless of politics, if you envision any photos in the past of President Obama interacting with children, right? He's always like, if there's a kiddo smiling, like he's a very good mirror, especially with kids, right? And so if you imagine someone with Parkinson's is interacting with someone who's in a really great mood and they're laughing, they're smiling, but the person with Parkinson's has a masked face where their facial muscles are literally stiffer. So they can't physically emote in the same way, right? If you're excited about some news, you got great stuff at work, and your loved one's like, oh, that's great,
Yeah.
right? They might even be feeling, oh, that's great, right? But it's not coming through. Then how does that impact you? And
Mhm.
being able to tell them that, it's not under their control. But if they're aware, they might be able to, like some of our physical therapies and speech therapies, they might be able to over exaggerate when they're happy, and meet you sort of halfway.
Thank you for that. All right, we're going to switch topics. Temperature regulation. The question came in. My husband has such temperature variation throughout the day. First, he's hot, sweaty, then cold and shivering with hands and feet like ice. Any suggestions of how to handle this? It even happens at night and interferes with sleep.
Really common, very under recognized and under discussed. So we call this thermodysregulation. Um, so I explain this to some of my families as like, this is part of that autonomic dysfunction, sort of those functions that we take for granted, blood pressure control, heart rate control, bowel bladder control, things like that, that it's almost like the thermostat for the person with Parkinson's has sort of been like elbowed accidentally and it's hanging out from the wall. Still connected, right? But it's kind of dangling by the wires and you can see that it's like not quite keeping up with where it needs to be. And so it is very common that the person who used to be totally fine, no matter what the environment was doing around them, is now really hot when no one else is, or really cold when no one else is. And that same person could experience those same temperature fluctuations, within the span of a few minutes or within a given day, even though they used to be just fine. There's no good medication treatment for this. I would say, recognizing it is number one. Making sure that, they aren't having a fever, right? So is this something that is, absolutely brand new and other things are going along with it? Check temperature to make sure that this isn't something out of the blue and an infection that we need to worry about. But if this is something that they're kind of experiencing and this has become their new norm, it is really common to be dysregulated at night, to be, cold getting into bed, and then, drenching sweats overnight. And so thinking about breathable fabrics and layers, both in clothing during the day and in clothing and in bed sheets at night. So this might be a time where, if the person with Parkinson's is sharing a bed with someone else, two separate comforters, right? Maybe, the heavy duty, I'm in Chicago right now, it's still cold outside, right? The heavy duty winter comforter goes by the wayside or gets split and goes to the bed partner. And the person with Parkinson's uses, a spring blanket or something thinner, with a flat sheet maybe. It's hard because it can be really hard to maneuver around in bed. So we want to keep that in mind too. But one or two thinner layers that they can adjust versus a couple of heavy layers. And especially at night for sort of overheating, something that can be really helpful. I didn't plan this, but I have sort of an example. Um, you can get little clip-on fans. This actually clips on to a headboard or to a nightstand. There are some of them that are smaller, less unwieldy than that can be remote controlled. So pointing that towards the person with Parkinson's so that you're not necessarily relying on jacking up the air conditioning, or turning on the ceiling fan and then the bed partner absolutely freezing. Um, the person with Parkinson's might want to wear, summer PJs, right? Breathable, light fabrics. And the bed partner could be wearing flannel, right? So recognizing that we may need to kind of make those adjustments. And then during the day, thin, breathable fabrics in layers. So things like cotton, things like linen are more breathable. Um, Things like bamboo is actually like a natural, ecologically friendly fiber that's in a lot of things. And that is actually very breathable and kind of moisture wicking. So when people are really sweaty, that can be helpful. Thinking about layers in those types of fabrics versus heavier things or like polyester is not great for sweat or for overheating.
Thank you.
Yeah.
All right, a topic that some people are squeamish to talk about in a group setting is sex. And this care partner writes in, what suggestions do you have for erectile dysfunction? We're desperate for help. Our movement disorder neurologist referred us to a urologist. And of course, the urologist wasn't helpful. And, saying there are other ways of being intimate is not helpful. We simply want to have intercourse.
Yeah.
Would you answer that, Jori?
I think number one, way to be brave and put that in to a question forum. You are not alone. Depending on the study we look at, erectile dysfunction might be one of the most common symptoms of Parkinson's in men. And men are not alone because sexual dysfunction is also probably one of the most common Parkinson's symptoms in women. We just don't ask about it enough. So, not alone, not alone, not alone. And the science still lags behind where we would want it to be for this. You know, starting with a movement disorders neurologist is a great idea. There are some medications, some oral medications out there for erectile dysfunction. So if one hasn't worked, often people will consider trying another. I will say most movement disorder neurologists, we don't get any training in this or very much training in this. So it does probably rely on, speaking with either your primary care doc or a urologist to talk about what are the options. And if one oral medication didn't work, there may be others that do, right? Or it might mean that dose was too low. We should try it again. We should adjust the timing, just like any other medication. If those don't work, there are other options. And so neurologist, not urologist. So I cannot speak, with any degree of expertise on this, but if the oral medications don't work, there are more invasive treatments. There are pumps, sort of manual or vacuum pumps that can be helpful with erectile dysfunction. There are injections that can be helpful. So there are other options. It sounds like what this person was told is, well, intimacy is more than just intercourse, which is true. And I would say, there are some really amazing talks out there online. Sheila Silver is a phenomenal speaker who talks specifically about intimacy and Parkinson's, and has helped to promote that idea of, if intercourse has become more difficult, more challenging, more uncomfortable, how else can we connect? And that should be part of all of this, but not to the detriment of saying, well, just forget about intercourse, whatever, we're just going to cut that out of your life. So I hear all of that. And I think continuing to explore just the same way that if you went to anyone and were told, this is all we have to offer, I don't have anything else, sorry, we've hit the end of the road, you'd get a second opinion, right? I would hope you should get a second opinion if you hear that from someone about any symptom. And so, I think talking with another urologist is reasonable. A lot of urologists may really focus on bladder stuff, and they may not be as up to date or as comfortable with erectile dysfunction and sexual dysfunction in general. So asking, who would you recommend, right? Going on some of the local forums. If there's a local Parkinson's group in your area, you're not alone. Someone else is asking this question and wanting this advice. Who are they seeing? Asking the movement disorders neurologist, this urologist wasn't super helpful for what I'm specifically asking. Do you have another recommendation? I think keep asking around, and we need better treatments. This is not something that is, heavily studied, but you are not alone, and keep advocating.
You mentioned there are prescriptions or medications for erectile dysfunction. Are there any that are contraindicated for Parkinson's, or are they safe?
That's a really good question. It depends on what else the person is taking and what other medical conditions they might have. So if someone has really low blood pressure, we need to be careful because some of these medications can lower blood pressure. So like many other things, it's a trade-off, and we sort of have to weigh the pros and cons. I think the other thing that I forgot to mention is that there are sex therapists and sex educators out there. So, this might require medical intervention, and also, a sex therapist, a sex educator, who really this is what they do. They can't prescribe medications, but they can listen and hear what's going on and what the challenges are. And they understand the physics of everything, right? And say, you know what, maybe try this position. Maybe you're going to use, this pillow and this bolster, and, you're going to be here and you're going to be there. We're going to take the meds. We're going to wait this amount of time, and then we're going to try. right? So I think just like an interdisciplinary team benefits almost every aspect of Parkinson's disease, probably this is one of those highlights, to try to rally, everyone who has expertise in these areas. And it's more taboo, it's a harder thing to bring up, but it is a huge important part of your connection, of being a human. So keep advocating.
Yeah, thank you. All right, we're going to shift a little bit to cognition. We've got some questions that had come in ahead of time and some questions in the chat about cognition. I'll start with a question from the chat. When is it ever appropriate to communicate with a care provider about cognitive changes I'm observing in my spouse without talking to my spouse first?
That is a really good question. So, I think this is a really tough question. What I would say is I'll give you a little bit of background of sort of communication with healthcare providers and what the sort of rules are governing some of that. You can always, as a concerned person, to your loved one, you can always send a message. If you're on an electronic healthcare portal, I would say, that's a good way to do that. Or you can call the office to communicate your concerns. If you are not their designated healthcare power of attorney or, sort of person, if you're not listed, so I've certainly had children and other folks in the family call and give me information. If they are not the designated person, legally, I should not be providing information about the patient to them, right? And so I can receive any information, and that may often does impact what I'm thinking about and how I might ask questions of the person in front of me. And so I would say, absolutely, if you are noticing things, right, and you are likely noticing things that your loved one maybe does not have as much insight into, right? And so that is fair game. It is important to share that with their healthcare provider. The challenge is, one great thing, but it's sort of a double-edged sword, is some of the recent legislation in the last few years has made healthcare records much more accessible, which
Mhm.
means if you send something in the health portal to me, for example, you could send a message, but your loved one presumably has access to the same portal and they will see your message if they go looking, right? So that's really tricky. If you call the office, we have to document everything as part of a person's record. Um, in case I'm out of the office and something happens and someone goes, why did Jori make that change in medication? Why was she thinking that? I need to show my work, right? And so, we will write down if we talked with so-and-so about such and such, here's the day that that conversation happened and here's what we talked about. So it is part of the medical record. And if your loved one is looking at their medical record, they will see that. So I think to some extent, it depends on the relationship. I've certainly had family members who will come to a visit and write something on a note and will pass a note to my medical assistant and ask them to give that to me ahead of the visit. It is more common than you might imagine. I will always look at it. I will always read that before I go into the room. If it's short, please do not bring me a binder because I just can't. But it's still going to be documented, most
Mhm.
likely. So I think if you're noticing something, you can always bring it up in the space of the visit and say, honey, would it be okay if we talk about something that I noticed? And maybe it's just me, but I'm wondering if this is part of the Parkinson's. I noticed, and having specific examples so that it's not a you always or you never, right? It's the other day when you were doing this thing, I noticed that you forgot or you used the wrong word or this happened. And, is that a senior moment? What is that? And when do we need to be concerned about that? Right. And then turf it to the
Lovely
top.
approach. Yeah, lovely.
Yeah. So I think there are a lot of different ways. It really depends on your relationship.
Sorry to interrupt you there. Just that was such a nice way to approach it in the doctor's office. Yeah. Another question that came in that you might yeah, a similar cognitive question. My husband, who's been living with Parkinson's for 7 to 8 years, asks me a question such as, "What time are your parents arriving today?" I'm stumped as what to answer. My parents are dead. And so do I tell him, or do I play along and say 6 o'clock and hope that at 6 o'clock he's forgotten that he even asked the question? Is this Parkinson's? Is this a Parkinson's delusion?
Yes, this is Parkinson's. Yes, this is, either a delusion. So a delusion is a fixed false belief that usually keeps coming up over and over again. So sometimes people are paranoid. They're convinced that, the government is watching their computer activity through the wires, or there's, the birds are following something, right? And it comes up over and over and over again. So it might be that, he feels like the parents are still really there, or he may be having hallucinations at times and seeing that, or just having a hard time kind of orienting at time. Um, when we argue, when we try to convince people out of delusions or hallucinations, we never win. We just never win because their brain is producing that and telling them, at least for a moment, that this is true and this is reality. And the last thing we want to do is pit you against what their brain is telling them. It just never goes well. So we always want to align with them if we can, right? That's the best way for them to feel safe, to feel reassured, and for you to avoid some of that anger that we started with, right? So I would, at what time are they coming over? I mean, pick your therapeutic fib. Okay, so that's the term, right? Um, you could say 6 o'clock and hope that at 6 o'clock he's forgotten and moved on. You could say, you know what, they couldn't make it tonight, but we're going to reschedule for next week, right? So you can spin it however you want, but I wouldn't try to argue, and I wouldn't try, especially this gets so hard with thinking that people who are deceased are still around. But what winds up happening is that it's heartbreaking for everyone because you're trying to convince someone who believes that a loved one or a pet, right, is still there. And it can be heartbreaking and grief inducing, not
Oh,
only for the person to go through, right, but it's heartbreaking. It is heartbreaking as the care partner to have to give them this bad news again and watch that and sit through that. I've done this and it is gut wrenching. And then you are distraught and they've forgotten it. And they'll ask you again, what time are they coming over? So not only for your loved one's benefit, but for your own benefit, don't put yourself through that. It doesn't, you're not playing into it. You're not making the hallucination or the delusion more likely to happen because you don't try to, negate it and tell them it's wrong. You are not. Their brain is what's making this happen. So
it sounds like this person should also have a conversation in clinic with you
yeah,
and use the strategy you employed on the last question,
yeah,
sort of asking permission to bring up a
yeah.
topic that you've noticed. Is that what you would
Yeah,
recommend?
absolutely. Absolutely. And I think if someone is at that point where they're having kind of those delusions or those hallucinations where they're really struggling with what's real, what's not real, that should definitely be a trigger for a care partner to think about what does my loved one have control over right now
Mhm.
that could be impacted by some of these false things coming in the way? Are they still controlling the finances? Are they still driving? Right? Because this could be someone who gets behind the wheel and thinks, oh, you know what? I need to go visit so and so. I need to go check in on them, right? I need to go check in on your parents, right? And just heads off in the car and we don't know where they are, right? Um, so I think if we're seeing those kind of delusions or hallucinations, taking that broader step back, talking with their neurologist, you know, if this is happening, what other kinds of things do I need to be thinking about? What other kinds of things do I need to be sort of checking safety wise on?
David asks in the chat a little earlier, um, we are dealing with hallucinations and have been taking Nuplazid. for about 4 months. It helps some, but they're still happening. I'm assuming the hallucinations, they're still happening. What is your experience with this medication? And then he also says, we'll see the neurologist next week.
So I think it's a really great question, David. So for folks who aren't familiar, Nuplazid is the brand name. Pimavanserin is the generic name for this medication, and it is the first medication that was developed specifically for Parkinson's related psychosis. Doesn't mean it's the only one that's used. So for all the decades before that, and still, there are a lot of other medications that we use. I think everyone's experience as a healthcare provider, as a movement disorders neurologist, is different. Um, Personally, I don't use a lot of it in my practice. Um, I think some of our other medications can be more effective if the hallucinations are more severe, more persistent. Um, I've found that can be helpful very early. But if things are getting more intrusive, if they are really bothersome, if they're causing agitation, um, we might try that. But more often than not, we need to move on to other things that offer some more relief. So, but that being said, I have colleagues who do use it more regularly. So I think it really is based on all of our experiences. My clinic population tends to be a more advanced, later stages of Parkinson's. So I may have a very skewed view of things. But that's my personal experience. So always, for any medication, whatever it is, if you've tried something, you've added something, you've adjusted something, please tell the person prescribing, here's what's better, here's what's different, here's what's worse, here's what we thought was going to change and hasn't. Or, we think the hallucinations were happening every single day. And, they were on a scale of 1 to 10, they were a 9 out of 10. Now they're happening twice a week and they're a 4 out of 10. Right? That's actually a really big improvement. I wish I could say we had something that's perfect and that's going to go from every single day, 10 out of 10 to 0 days, 0 out of 10. Probably not, right? Not without a lot of other side effects getting in the way. So I think just talking about expectations for any medication is always going to be important, and know that there is tremendous variability. So I am in the same breath telling you, ask your neurologist what you should expect. And your neurologist may tell you it's really hard to know what to expect because everyone's different. And that sounds crazy. And that is unfortunately the truth, because if you've met one person with Parkinson's, you've met one person with Parkinson's. So, um, your mileage may vary.
Another question for you. Yes, that got a laugh from our audience. One more question related to cognition. That came in from the audience earlier. What is the relationship between dementia with Lewy body and Parkinson's? I know we've gone
Oh,
over this before. It's such a hard thing for all of us lay people to understand.
it's a hard thing for all of us non-lay people
Thank
to
you.
understand. Okay. Can I be very clear? So this is really, really confusing. This is my silly chicken and the egg under an umbrella analogy. So bear with me. Okay. When we think Parkinsonism, okay, meaning the slowness of movement, stiffness, tremor, trouble with walking, sort of the movement parts of the movement disorder of Parkinson's. When that happens first, right, and someone receives a diagnosis of Parkinson's disease, and then at some point later on, not for everyone, but for many people with Parkinson's, they will experience cognitive changes, changes in attention, concentration, decision making, levels of alertness that can kind of fluctuate, and may have those hallucinations, right? When those things happen, then we say that person who has Parkinson's now has Parkinson's disease dementia, which is not a separate second diagnosis. Like, we don't say someone has Parkinson's and also Parkinson's constipation, right? It's just part of it, right? The orthostatic hypotension, it's all part of it, right?
Mhm.
And not everyone has all of the parts, but it's part of it. right? It's like you've got COVID. You might not have diarrhea, but the person next to you in the house does. It's all still part of COVID, right? So if someone has the movement first, later develops a dementia, Parkinson's disease dementia. However, there are people who develop the dementia symptoms first, the same dementia symptoms, and either later on or around the same time also get the Parkinsonism. So someone's first symptoms are they're struggling to find their words, they're getting kind of turned around when they're driving, they're having these fluctuations where their loved one sees them and is like, what's happening? Come back to me. And 5 minutes later, they're fine, right? And then they notice a little bit of a tremor or that their walking is slowed a little bit. So basically, the chicken and egg, the Parkinsonism chicken, the cognitive egg, for most people, chicken, then egg. For other people, egg, then chicken. Okay. If it's egg, then chicken, we call that dementia with Lewy bodies. And if you have both, regardless of which order they arrived in, we call this Lewy body dementia. Isn't that just the same words scrambled in a different order? Yes, it is. It's part of the reason for the egg description. Okay. Yes, Lewy body dementia is an umbrella term that includes Parkinson's disease dementia and dementia with Lewy bodies. So how are these things related? Whichever symptom starts first, we know that when we look at the brain of someone who has this under the microscope, right, what we see are these Lewy bodies. So a Lewy body is on a microscopic level inside a brain cell. It is a collection, a sort of walled off garbage bag of misfolded protein. So that protein called alpha-synuclein has a job in the brain cell. It's doing its thing, okay? And then it's, for some reason, it goes rogue. It changes its shape. And once it changes its shape, it no longer does its job. And it can also bump up against other normal alpha-synuclein protein, cause that to change its shape. And then you set off this domino effect where they all bump into each other, ball up, aren't doing their jobs, and are basically collecting inside of a brain cell, glomming up the works. The brain cell has all kinds of amazing mechanisms to try to protect itself and stop things like this from happening. And one of those mechanisms is to wall things off that don't belong. And so it walls off this misfolded protein into this little thing that we can see under a microscope called a Lewy body. In people who have Parkinson's disease, chicken, then egg, we see Lewy bodies deposited in the brain in a certain path, kind of chronologically. Early on in Parkinson's, we really only see Lewy bodies deep in the brainstem and in the area that controls smell. And as time goes on over the course of years, it's almost like the Lewy bodies kind of follow a hiking trail and they're deposited in a certain area along the brain over time. In people with the chicken first and then the egg, dementia with Lewy bodies, we see Lewy bodies all over the hiking map, all over those same exact areas, but all at the same time. So someone with Parkinson's, it would be very unusual to start having visual hallucinations around the same time that they just start having their Parkinson's. Because it takes years for those Lewy bodies to spread from deep in the brain up around the front of the brain, all the way to the back of the brain where hallucinations happen. But in dementia with Lewy bodies, they can all start at the same time because it's like someone detonated a grenade of Lewy bodies and they just went wherever they wanted. So oftentimes people can be misdiagnosed. So someone may have chicken and egg all at the same time. And it, depending on who you see, if you see a general neurologist, if you see a movement disorder doc, we are trained. We hone in on that tremor and we're like, Parkinson's, right? And we might make the Parkinson's diagnosis. And depending on how late we're running and what else is going on, we might not ask about the cognitive stuff. So I have a lot of people who I see who are told that they have Parkinson's, but are having hallucinations, and the cognitive changes have clearly been happening for a while. And that person would more appropriately be diagnosed as dementia with Lewy bodies. However, it's all, I think it's very much part of the same spectrum. We may recognize down the line, people disagree on this. It's the same protein. They're the same symptoms. It's just a timing question. We use the same medications. And so how we categorize this may evolve as time goes on. The challenges for care partners are very, very similar. It's the same symptoms, but it's a question of how quickly things are changing and sort of how much time do you have to wrap your arms around, okay, I finally understand this before sort of that next symptom comes up. And for care partners of a loved one with dementia with Lewy bodies, it can be really, really difficult because it's all happening all at once and on a faster time scale. So I have the privilege of working on a study that is open to care partners of loved ones with PD with cognitive changes, with Parkinson's disease dementia, and people with dementia with Lewy bodies. Anyone under this Lewy body dementia umbrella. Basically, you got a chicken, you got an egg, you're my people, come to me, it's fine, we will handle it, right? Because there's just not a lot of guidance out there and it's really confusing.
Yeah. I'm going to ask our colleague Annie to drop the link into the Persevere study in the chat for those of you who are hearing about this for the first time. And Jori, wouldn't it be fun if we could get your kiddos to draw chicken and egg analogy?
Oh my gosh.
Then we have a graphic, because the way you described it is so illuminating, and having a visual could be really helpful too.
There is a really goofy photo of a chicken under like what looks like a cocktail umbrella that I throw into some of my slides, but I think it's probably copywritten, so I probably can't like flash it anywhere. But
maybe we could take that.
Yeah.
Thanks for that explanation. Got about another 10 minutes here. I'd like to answer some questions from the audience. If you in the audience have any more questions, Karen from the audience, this is a completely different topic from cognition now. Karen from the audience says, my husband often cannot open his eyes and needs help prying them open. What to do? What is this? How to help?
That's a great question. So that is most likely something called eyelid opening apraxia. That is your Jeopardy term for the day. So what that means is someone can, either both eyes can close. Sometimes I have folks where sort of one eye is closing and the other eye is still open, and you're like, what is happening right now? It is not in the person's control. They are not falling asleep. They are not asleep. And they may actually not be aware that their eyes are closed, which seems really hard to understand. But it's almost the same way as someone could be sitting there dyskinetic and may not recognize that they're dyskinetic because their brain has adjusted to this, and that's part of their new norm, right? And so recognizing that that's going on, that is something to talk with the movement disorders neurologist about. For some people, that can respond to botulinum toxin injections or Botox injections. Which is something that we give. They're injected sort of around the eye muscles to try to weaken those muscles that are closing inadvertently. Sometimes if it's happening and it's not very severe, if the person may not be aware of it, if you tell them, can you open your eyes? They might be able to kind of summon them open. You might often see that they're using extra muscles to kind of try to activate those muscles that aren't working well. Sometimes something as simple as a touch can actually overcome it. So just touching the eyelid, the person may be able to touch their own eyelid, not even to pry it open, but just that simple touch is sort of enough of a distraction, of a cue that it can help. Sometimes a care partner may need to actually open the eye, and then they can keep them open. It does, tend to kind of recur. So you may see the lids kind of close on their own. But not for everyone, but for some people, botulinum toxin injections can be helpful. These are things that are done about every 3 months. So it's not taking a medication every day. There's no, side effects. Is it going to make me sleepy? Is it going to give me constipation? All of this, it really is something that stays where we put it. But it is a procedure. You have to, come in and do that every 3 months. And it is part of the Parkinson's.
Yeah, of course. We just got a question in from somebody who has watched one of the sessions we did earlier in the year. in which you were talking about tips and tricks for care partners to help a person with Parkinson's. And it says your suggestion for a seatbelt extender is a great idea. And you mentioned you can find it on Amazon. I believe you said to get a hard plastic one. Is that correct? Also, after searching, I can't seem to find the one you talked about. Can you remind us?
Amazon, don't fail me. Okay, so what I mean by that, I don't have like a good example. I don't have a prop closet, unfortunately. Is like it's really hard for people with Parkinson's because they can have really stiff shoulders, right? So it can be really difficult for someone to reach back, grab the seatbelt, and then reach all the way down, right? That's almost an LSVT big exercise to do. So if the person with Parkinson's is struggling, or if you're a care partner and you're standing outside of the car, you're in your driver's seat and you're trying to reach over and maneuver, that is terrible on your back. So there were, I'll see if I can search for it now as we're talking.
We'll search for one. So when
But
yeah.
but it's basically if you think about, where you plug your seatbelt into, the hard plastic that is nested inside your seat that you're going to plug the belt into. There are seatbelt extenders that basically plug into this and pop up and stick up further. And so it essentially just raises where you're plugging in your seatbelt by about 4 to 6 inches. And so it makes it a little bit easier if the person is buckling themselves or if the care partner is buckling them, there's less bending and stretching. The problem is if you type in seatbelt extender, there are those. There's also like if someone has just a larger body size and the seatbelt length is not big enough to reach, that there are seatbelt extenders that basically just plug in one end to the other and it's just more of the fabric. That's not what we need. So
Another question that we get a lot from our audience. Any advice on how to get my person with Parkinson's to agree to see a mental health counselor? I think it would be helpful for us to do together, but they don't want to go.
it's really challenging. I will say it's very difficult and there's so much stigma, unnecessary, inappropriate stigma around mental health, right? The number of times that I heard people say, oh, they're depressed, it's all in their head. I'm sorry, I'm going to tell you, as a neurologist, everything's in your head. Okay, we just talked like Parkinson's is in your head and is making you constipated. Okay, Parkinson's is in your head and is causing erectile dysfunction, right? So everything is in your head. Okay, mood is in your head, anxiety is in your head. This is all right related to chemistry in the brain, electricity in the brain, to the physics, the actual biology that's going on, right? And I probably don't have to convince you if you are the person listening to this and saying, I know, I want my loved one to understand, right? But trying to help them recognize, are we getting treatment for your tremor? Yeah, because you can't control it on your own, right? This is not something that you've been able to snap yourself out of. What about, the foot that's turning in or the toes that are clenching, right? Can you snap yourself out of that? Can you pull yourself up by your bootstraps and make it go away? How about the constipation? No? Okay. Why do we think that any of these other symptoms are somehow in a different category, right? That is absolutely wrong. Right? We can talk about our feelings and that can be very, very helpful. It is not to say that, talking about it and non-medical treatments are not effective. They are. But what I often see is I'm having mental health issues and I'm just not going to accept any treatment, right? So no treatment is absolutely going to be a problem. Starting by talking about it. Number one, this is part of your Parkinson's, right? If the constipation bothers you, we address it. If the blood pressure bothers you, we address it. Why are we not addressing it? And what I would say is we also know that depression is one of the biggest predictors of quality of life. So I could give you the best, most wonderful tremor drug if we had something so perfect, right? We don't. I'm sorry, I'm not holding out. And if you are depressed, you're not going to take it, right? Because the depression is saying there's no reason, it's not going to work, it's not going to help me. there are bad side effects. It's just that negative voice. And so until we address that negative voice, the physical therapy is not going to work, right? All of these things are not going to help. So, however we need to frame it, and I find that that's really different depending on the person in front of me. I generalizing, but I think it's harder for our men with Parkinson's. We do not live in a culture in the US where mental health among men, I mean, mental health in general, but specifically among men, is something that is discussed widely, right? It affects our men just as much as it affects our women. It doesn't see gender. It doesn't see, sex. It just is there because this is a chemical change. Um, I think different cultures really respond to this differently. I take care of a lot of Hispanic and Latinx, men and women. And the machismo culture for a lot of my Latin men is a really huge barrier to overcome. Um, and it can be overcome. And I have seen many of my folks really thrive once we can take care of the mental health aspects and recognize it as just another part of this fun mix of symptoms, right? But if the goal is to be a pillar in the community and to take care of your family, this is the way to do that, right? Is to be in control of that as well. So talking with someone, thinking about medications, thinking about treatments for it, I think is really powerful. Support groups. So sometimes folks will not listen to the person closest to them. I don't know if any of you are married, and if that is your experience, but right, to being together with other people. So the exact same recommendation that you might have given, for the last 10 years could be viewed as something completely new and different if it is heard from someone else's mouth, right? So is there a support group? Is there an exercise class? Even better, okay? Because support group still has mental health stigma written all over it. Our men have a harder time going to support groups. They've just not been as frequently male dominated. They're more often our women. And people are working to change that. But a rock steady class, a cycling class, a something where everyone else in the room has Parkinson's. So we don't need to worry about the stigma because everyone gets it. The conversations that happen when someone gets into one of those classes, the conversations that happen in the locker room, that happen in between on the water break, that happen before or after class, those are the conversations where I see people actually changing behavior because someone else, Joe on bike number 3, said that he's got a great therapist, a person he talks to, not a therapist, a person he talks to, you know, and he's been really helpful. Awesome. Did you get the name of the person he talks to? Cool. Right? I mean, whatever we need to do to find what's going to fit for any individual.
How did an hour go by so quickly,
They
Jori?
always do. It's because the audience has the most amazing questions and feedback. So
And there's still more. But thank you. Thank you for joining us. We will continue to produce content for our care partners. We've got our monthly care partner meetup. For those of you in the audience who don't know about that, we will send you a link for that, or we'll put a link in for that. For those of you watching on the video, or go to our website and find our care partner meetup information. And I think Dr. Fleisher is going to join us maybe in July for that care partner meetup. So maybe we could answer some of these questions there, and we'll try to get back to all of you. I'm going to look at my notes here. I've lost track of what let's see, what else? This is the final session of our care partner training that's planned for this year, but we have that whole host of programs that Dr. Fleisher and I work together. Well, really, Dr. Fleisher, I just was here helping her. We have 10, 12, 14 sessions for all of you. So please join us and watch those. And also later this year, we'll have a Living Well Today webinar for our care partners. So please continue to check back with us at dpf.org. And please consider joining Dr. Fleischer's Persevere study So people we know who've joined it says it's amazing. Thank you for being here. Thank you in the audience. This has been really tremendous.